down. So again, I'm Jeremy Holland, Director of AI Research over at Apple, and thrilled to have such great turnout here. And we're super excited to have our next speaker, which is Ayanna has an amazing background. She's robotics kind of expert extraordinaire. She's been voted the top 23 technical women in the world by Business Insider. Top 50 leaders, women leaders in the world by Forbes, has a history of working with robotics all the way back to NASA, heading up a group and lead technologist in the Office of the Chief Scientist, I believe, in NASA. And then more recently at Georgia Tech, she's built department and heading up to the School of Interactive Computing there. And then ton of work on AI, user interaction, assistive work with AI. Over 250 peer-reviewed publications have come out of the research. It's just phenomenal amount of contribution to this field. So anyway, I'm thrilled, super excited, and we should all be honored to have you present today. Welcome, Ayanna Howard.
Thank you. All right, so what I'm going to do with this time that I have with you is introduce you into this world of robotics. So I've been doing robotics for a number of years. I was mentioned my first career was at NASA, thinking about future Mars rover missions and how do you embed intelligence, human intelligence, into these rovers. And then when I went to Georgia Tech, I was thinking about how do you take the information and all of the things that you learned, that I learned with building teams, and apply it to people here on Earth. And so what that meant is that my career changed, it switched. So I was science-driven robotics, sending rovers even at the first part of Georgia Tech, sending rovers to glaciers, engaging with scientists to look at how to grab data and things like that. And I switched to what I do now. And so what I'm going to talk to you about is this world that I've been kind of dumped into and the lessons learned about how is it when you're a technologist and you go into a field that is totally different, how do you actually engage that demographic so that you have technology that works? I love gadgets, I love building things, but I've had to rechange my thinking process of what it really means to be a technologist that has value to the world, not just to my lab and my students. So now what I do is design robotic technologies, assistive technologies to engage children with special needs, children with developmental disabilities and things like that. And so I want to lay the foundation first because a lot of people, unless they've interacted with someone directly with a disability, sometimes like, oh, this is nice, this is charming, but it doesn't impact me, and I'll listen and maybe I'll like text someone. But the fact is that if you live long enough, most likely in this room, you will have an acquired disability at some point in your life. And so what is this? If you think about what a disability is, there's the classical definition, which is you might be diagnosed with a disability, like with the kids that I work with, from when you're born, so a child with autism, child with cerebral palsy, but you might have acquired. And as you get older, things age. When you hit that 65 and 70 and you can't see quite at night and you're not quite likely to drive anymore because you might hit someone, right? Like your change of life has happened. And if you forget, because everyone starts forgetting as they get older, your brain cells, they do kind of deteriorate. There's so much information that's there that trying to remember everyone, like names of students that you graduated 20 years ago, like it becomes really hard to remember. And so you have a change in your function, in what you're doing every day. And so the fact is that with countries like the United States, Japan, Europe, for places that have beautiful healthcare where we live long lives and we like to be healthy, the stats are we will live on an average 8 years with a disability. Now that could be something, arthritis, it could be that when you're typing, you can't type for 8 hours a day all day. Maybe you have to do 2 and then you have to take a break because it's painful. But these are changes and we will all live with this, and you hope you do because that means you're still living at the age of 75 and 80. And so taking that into account, it means that the technologies that we are designing today, we're going to be the users of that technology later. right? And so I always think about, as a technologist, this is something we should care about, not because maybe it's not our passion, but the fact is that when we're 70, it would be really nice if, when we're using a technology, that someone just as smart as us was designing it, and so we can really make a difference. And so that's just my high horse that I always go. I think we don't do enough in this space, and the selfish reason is that it's actually a space that will help us in the future. And so I also tell my students, so you can't screw it up because this is your technology. And so they really do comply with that. So who do I work with? I work with children with special needs. In terms of demographics, there are a diagnosed, recorded, about 150 million children worldwide with a disability. We actually think it's more, only because there are still some countries where parents aren't going to disclose. There are still some places where having a disability is not an accepted norm. And so we actually think it's higher. But we'll just go with what's recorded is 150 million. In the United States, and this is just in the US alone, $1.6 billion in US pediatric rehabilitation. That is not teachers and special education. That is not all the other things. It's just in rehabilitation for pediatrics. So imagine then that number of kids then becomes adults, and then you add in the additional of individuals who might have had a stroke that have to go rehabilitation, veterans that come back that might go through, like all those other things. This number is astounding if you start adding it up. And so I think about what can we do in this role. I mean, when we put in robotics and we put in AI technologies, I mean, this is the reason why it's important. It's not we're going to do this AI because it's going to improve quality of life. No, it really is going to improve quality of life. We don't have enough healthcare workers, we don't have enough clinicians, we don't have enough special education teachers to address the increase in the numbers that we're facing. And so AI really does have a role. It is like that one thing, if we can fix it and figure it out, it can make an amazing impact in terms of the disabilities. I specifically work with two target demographics of kids. One is children with cerebral palsy and children with autism secondary. And why? It's because I create these robots that interact with children based on rehabilitation, based on therapy, and I just say it's exercise, right? And so children with CP, a large majority of them have limitations in their motor skills, and so what we're doing is we're exercising so that they can improve. And believe it or not, there's a demographic of children with autism who also have limitations in fine motor skills. And so what we found when we started off just working with CP, we would start getting these kids and these parents that would come to say, hey, my child has a motor disability. I'm like, wait, there's no CP here. And they're like, no, and we would watch, we do the observation, we're like, no, they definitely can interact with our robots because I see that they do have this motor limitation. And so what we found is there's also a larger demographic of children with autism with motor limitations is more than children with CP. And so we work with both target demographics. So kind of, what do you do as a technologist? I was doing science-driven robotics. Like, I interacted with scientists, which, okay, they're people, but they were scientists. And now I had decided, and there's a long story of how I decided that I was gonna work in this pediatric space, and these were real people. I mean, like real people, right? And so what do? I'm a technologist, I wanna work in this space. Okay, I don't really know what it means. Like, what does this actually entail? And so the first thing that we learned, and I learned that I have my students anytime we're doing something, is you have to live in their shoes. You have to go in and you have to listen and you have to observe. You can't go in and say, hey, here's my gadget, here, use it because I know it's gonna be best for you. It's about, okay, let me observe what you're doing. Let me observe your practices and then ask questions. I saw that you did this. Can you explain why that is? And what you find, there's so many low-hanging fruits that you can, oh, wait, that's the reason why you do that? We can fix that. Like, that's an easy problem to solve. And it's amazing that when you're living in someone else's shoes and observing, there are so many things that we can do as technologists that aren't like super, super, super hard. There are some hard problems, but there are so many like simple things like, oh, I can do that in 6 months. Oh, I can do that in 3 months, that would have so much value for this target demographic. And so we did a lot of observations. We would go into clinics, we would go into hospitals, we would observe parents and children. And the one nice thing about it is, as we were observing, we were also collecting data. We were collecting data in terms of, because we needed to figure out when we went back, what was this correlation? We asked this question, they did this. Did I remember? I think wait, who was first, who was second? No, here's the data. Okay, let's do an observation. And one of the things is when you start looking at videos over and over and over again, you're like, okay, this is getting kind of tedious. We need to design an algorithm that can actually code this, right? Because looking after hours and hours is like really, really boring. And so we design algorithms to actually figure out and codify things like when is an emotion exhibited? Who's taking the first turn? Who's taking the second? At what point is the clinician interrupting versus the kids? And that data then becomes this expert database system that we can then learn from. And so, and I would just tell you, it wasn't at the beginning that we were like, oh, we're going to design this expert system that monitors and records. It was okay, we need to record, we need to observe. There's a lot of things going on. Okay, let's just save everything, and then later on we'll figure out what's going on. But because of that, it meant that we had so much data that we can use, and we use that. Now, a couple of things about robotics. So we have the data, so how can we introduce robotics into this? Well, robots is easy. So if you think about healthcare and you think about robotics, at least now, most people are still fascinated with robots, right? So I can bring a robot into a clinic, into a child's home, and I can say, oh, I really would like you to work with my robot and do exercise and do therapy. There's no I don't want to. There's no am I going to get bored? It's like, oh, I get to have a robot, and can I keep it? Like, that's the one question. Number one question is, can I keep it after we're done? And of course, we have to explain, this is research. The study is only 8 weeks max, sometimes 16. And, we do have to take the robot back. But there's no issue about bringing in the technology. It's just that it has to be useful. And so we don't have to worry about, what is the customer engagement? Are they going to take it? Are they going to put it in the closet after a week? We haven't quite got to that point. Now, when we have robots in everybody's home, maybe this won't be the case. But right now, like most people don't have robots in their home. And so we are capitalizing on this fascination with robots to really engage our target demographic. The other thing we found out is that children move differently. So I talked about all this data that we collected. And interesting is very early on, we would have information about these kids, about their diagnosis, about their movement behavior. And so they would say, oh, this child, cerebral palsy, and they have all these clinical definitions, and they would say a scale of 2. They're like, scale of 2, what does that mean? So we figured out there's these things called clinical scales. And so we would say, well, I saw a 2 yesterday, and I saw a 2 today, but they move totally different. Like, I don't get it. Like, what is this 2 definition? And then it's like, oh, well, this is how you get a clinical measure. You bring the child in, and you do these battery of tests. And so these are functional tests. So maybe you have some blocks, and the child will, say, pick up a block and put it into a bin. And if they can do it, you get a score of 1. If they partially completed it, you get a score of maybe, half of a point. And if they don't do it, then it's like 0. So I was like, okay, and then you take up this entire batteries of tests, and you get this score that then corresponds to this scale. I was like, well, what happens if, they're partial, but, one day they, do it 1/4, and then one day they're able to do it like 3/4. Like, that's progress. It's like, yeah, but they get the same score. Now, I was like, oh, this is quite interesting. Like, the resolution that's here is not apparent. And so we talked about, I was like, well, how do you know if the child is improving? These are like absolute scales. Like, how do you know, improvement is gradual, just like with any kind of sport exercise. They said, yeah, we do have problems, because we'll have parents come in, and they'll say, my kid has improved. They were able to button their top shirt today. And it was like, that's an improvement. But the scales wouldn't show it. And so immediately we realized that one of the things we could do very early on was provide a means to measure improvement that was a little bit better than the scale. And I'll talk a little bit about how we did that in a second. The other thing is that we learned very quickly that children get bored. I mean, and I would say, I'm going to use kids' language. I'm so proud of you guys for sitting here and listening to me. This is inquiry behavior, just so you know, right? Like kids, and we are now working with infants, which definitely don't pay attention for a long period of time. Don't pay attention, right? Like, you can get them engaged for like a very small amount of time, And then you got to do something else. And the fact is it's not because they're necessarily bored, is that their whole environment, we saw the earlier talk about, learning and learning to play. I mean, their whole environment is about exploring the world, trying to figure out cause and effects, trying to figure out what is this world that I just suddenly appeared in and what does it mean? And so I can't spend an hour just doing one thing. Like, you can probably get everything I'm talking about in like 20 minutes. You don't have to be here for like 40. Like, again, you guys are sitting here, acquired behavior. Kids have not been trained that way yet. And so we had to figure out then, when we introduced this technology, we introduced robotic systems, we need to work with them for a given amount of time. How do we identify when they're engaged or when we have to change? If they're engaged, they're learning to play, but they want to play something else, we need to be able to figure that out so that, as they're switching, as they're losing attention, the robot can adapt. Because if anyone ever has kids or watch kids, they can play for hours and hours and hours, right? So why is it that you can't interact with them for 20 minutes doing the same thing under this definition of play? But you can, but the robot has to identify it. So we're taking all this in, and so we're like, okay, number one is we have to create a system that can interact, engage, understand movement, understand all this turn taking that we learn.
I don't have good memory.
And is socially interactive.
Your turn. That was close.
Can you have a turn?
Okay, so I'm going to stop there. So the child said, can I have a turn? So what we were doing here is it was a behavioral therapy. We were trying to teach turn taking through movement. So turn taking, this was a child with autism, had limitations in fine motor control, was the key, right? And this is like toward the end, so I showed the good part, right? Like the beginning, no turn taking, right? But after a while, it was if we had the robot and the robot emoted, what we found is that if the child didn't take a turn, the robot wouldn't emote. The robot basically wouldn't play back, right? But if the child took the turn, the robot was happy, socially engaging, was interacting. And that was the feedback that this child needed, was to be socially engaged with, to be interactive. And so the child would take turns mainly because I want to see this robot move and interact with me. And what we were able to show is after a certain time, that behavior was able to translate to another person, right? So it wasn't just a human-robot interaction, it actually translated to a human-human, i.e. feedback is, okay, this is a good thing. There's a positive thing that happens when I take a turn. Okay, maybe it'll work with this other human, but it's now a feedback mechanism. And so we were able to do that. So now, to get to this point, of course, requires a bunch of different steps, and I'm just gonna go through a few of them. So one is, how do you gamify this? So we use robots and we create games. We do everything from virtual reality games, and kind of the value of the virtual reality games is that if you have a child with a special need, child with CP, who's born with a disability, how do you record and how do you know that you're doing it right? So if any of you guys play sports, and if you've gotten hurt, I've gotten hurt, I used to play tennis, right? Like, you know when something is not working right? Like, you're reaching for something and you're like, it's not working. And you can do this auto-correction. Well, if you're a child with a special need, where's the auto-correction? There is no norm for you. The norm is you, right? And so what we found is that when you can see yourself playing in this, so virtual reality, the avatar is you, matches your movement. When you can see yourself, you can correlate that movement of self with what you think it should look like on someone else. And so virtual reality is really designed so that you can still do this correction. Like, I thought I was supposed to do this. I think I did that, but I'm looking, it's not doing that. Okay, so we do this auto-correction, and then the robot provides some feedback. We also use tablet-based games which I showed you with the child with autism. I always say, like, how's a tablet game? One is cognitive, but if anyone's played a game on a tablet, and if you position it so the tablet is a little bit distant, think about it. What you're doing is you're taking your hand and you're moving, right? You're taking your hand and you're moving. And if you position your assets in such a way, it also means that you're doing things like midline, you're crossing. And so you can, even though you have this small space, you can match it and change it and shape it so that you are achieving a motor-based protocol, even if you're adding in cognitive and behavioral aspects. And so we do a bunch of different games, and then we do metrics. So I'm going to talk about a few studies of the metrics. So remember these scales, we have these large scales. and we need to figure out how do you get a better resolution, so a finer level of resolution for improvement. Because our robots are going to come in, you might get 8 weeks. How do we evaluate improvements, and how do we associate that with the larger scales? And so we developed these metrics for evaluating scale, and we looked at all of the clinical literature, all of the things that are out there, and there's a host of these things that people with path length and movement units that people have studied and come up, and we came up with basically a subset of ones that seem to be most agreeable, and those are the ones we use, developed algorithms based on the data that we collected about how does a child move, how does a clinician move, can we correlate, can we find some measures that quantifies the child's movement. And then we have to figure out what does that mean. So in the clinical world, they have these things called baselines. So when a child comes in, they do these measures and they look and see where does this child fit with respect to a norm. So child comes in, if you ever remember the height and weight charts maybe when you were growing up, or if you have kids, kid comes in, and it's like, oh, your child's, they don't say that the child's skinny, they say the child's below the baseline, right? And they show, and there's your child below the baseline, right? Like that's the norm. And so these baselines are typically created by bringing in a number of individuals of the approximately same age, same height, and things like that to come up with a baseline. Now, we needed to figure out what is a baseline for a child with CP, which has all these variations. Remember, a 2 is not a 2 is not a 2. And so we, like great technologists, were like, okay, there's no possible way we can bring in 100 kids that all are 2 same age that move the same. Like, that's just impossible. So we are going to create a model that looks like a person. So of course, we created a kinematic model based on robotics, manipulator. So think about it. The manipulation world is designed to create these artifacts that can manipulate human objects, right? So their form factor, and there's a bunch of derivations that you can figure out, what is the velocity profile, what's the singularity, all these aspects. And so we basically said, in order to create our entire slew in terms of a baseline, we will model individuals, think of them as mini kids, mini versions of kids that would move based on the kinematics. So what is your arm length? What is your, path from how do you move, elbow to wrist? And we're going to model you, and then we're going to have the robot you interact with the real robot, and we're going to see how you move. We're going to collect these metrics, and then we're going to figure out is it actually work. And so this is what we did, and surprisingly, so beautiful equations. You can put equations in a paper and get it published almost anywhere, but how do you validate that it works? And this is validating it to the clinicians. And so we had to create the baselines, which we did, but we then had to compare it to real people. In this case, we started off with adults. We brought in adults. We created our model. We figured out, okay, here's your mini model of robot. This is how it plays. Here are the measures that we estimate. And then we're going to have you come in and actually play. And does it correlate? Did we get it right? Does our model accurately predict this? And what we found on a number of measures, deviation from path length, range of motion, elbow, shoulder, it was pretty good. It wasn't so good on path length. And this is one of these lessons learned that I'm just going to share with you. It wasn't good as path length. And we were like, what is it? Our robot's perfect, right? Here it's 2 lines, 2 points. It is a perfect path. There is no reason like our robot is wrong. But the fact is that people aren't efficient, right? Like they were doing things like, if I'm going things, they were using things like gravity, right? They were doing like weird things like this, and like, oh, then they would miss and they would go back. And like our robot was perfect, but it wasn't human, right? And at the end of the day, your baseline, who you have to model is the person. That is your ground truth. That is what is the baseline and the truth. And so even though our robot was perfect, the algorithms were perfect, that was not perfect for this scenario. So this was a lesson learned that our comparison, anything that we do, had to compare to the human expert, had to be compared to the human, not compared to other algorithms. That was really the holy grail of showing that it worked. So then we did it with kids, and if you think adults don't follow directions, like kids don't follow directions. So not only were they doing weird things, they were doing things like, using the wrong hand to pop. And we're like, no, dominant hand, non-dominant hand, like that's what we're measuring. And they're like, yeah, but it's a game, right? I want to win. They were doing things that just were not correct. And again, lessons learned is like, it's correct by who, right? This is a real system that needs to go out in a real world environment. There's not gonna be mom, there's not gonna be the researcher going like, no, 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 you can't do it that way. The kid is going to interact with the system the way that they are going to interact. And so your algorithms and your robotic systems has to function in that real world environment. And so let's see how that data does with this kind of scenario. So believe it or not, it didn't do too bad, not like the best, not things that I'm like, oh yeah, this is awesome, this is great. Got published in the clinical literature, not in the engineering literature, just so you know. Because of course it wasn't at that 99.9% accurate. It was at something that was acceptable in the clinical world, but not in the engineering world. So this was good. Then we had preclinical trials where we took out the system, we worked. This was an 8-week study where beginning we would take a baseline, 4 weeks we would measure, and then we would measure at the end. And what we found is, surprisingly, the system worked, which is like a surprise, right? Because you think it works, you claim it works, you've done all the testing and validation, and of course it's gonna work. But secretly, when you're in the real world, you have no clue. You have no idea, because you can't handpick your participants, you can't handpick the selection, you don't know what they're gonna do when they're in the home, right? And so you're like, yeah, it's gonna work, please, please, please actually work, because this is gonna take 8 weeks, and that will be a really good publication at the end, and if not, we're gonna have to repeat, we're gonna have to redesign, and that's just not gonna be good for a thesis. And so what we found is that pre-test, there was differences between how children with CP mood versus typical kids. At the 4 weeks after they were interacting with the system for 4 weeks, only 2 of the parameters were different. So this is movement time, basically how fast they played the game, and movement unit, which was basically the acceleration, deceleration phase when you're reaching for something. And so we were like, oh, 4 weeks, this is actually pretty good, right? And then at 8 weeks, there was no difference. I was really proud. I was proud of my students. I was proud of the technology. And then what happens is that the clinicians basically deflated the bubble of the technology high. And I was like, it works. And it's like, okay, yes, it works, but you have to be honest, right? It works for this small sample size. It works for, in terms of the scale, they were considered mild, so they were at 2. It may work, it may work for a child who is at 2. It may work for a child who's at 2 that's of the age of 10. It may, and like literally, there was all of these may. When I was like, it works, it's like, no, no, no. It works for this, and you have to be honest. And so when we published, and this goes with all of our work, even the technical work now, the limitation section is almost as long as the methodology section. And it explained why. So this is a vulnerable population. You don't get a lot of chances, right? And the fact is that if we tried something and it didn't work, and we don't talk about it, it means that another research group is gonna spend time and money to repeat it because they don't know. And that's actually a detriment to the community. And so by being honest and saying, this is when it worked, and these are all the limitations, it basically allows another researcher to build on top of what works and what doesn't work. That actually makes it so that, since this is healthcare, right, that allows it to continue to grow, and there's a sharing. And so even in our technical literature now, we write in like a pretty large limitation section of, okay, these are all the things that we tried that didn't work, or these are the limitations of we say it's statistically significant, but I mean, how many of you know that it's really not statistically significant, right? Like being honest about that, what it does is allows others to build on top of that, and it's a community. And that's one of the things I really value in this clinical world, is because they do this and it's accepted and it's a norm. And so we do it now in our state. And so I'm just gonna show you a couple of robotic videos since I'm running short on time. So we, just because I like robots that move, that's the only reason I'm showing these. So our robots do move, they interact, they are also very social. And the reason why we have the interaction is not because I go in and I'm like, oh yeah, we need to make these robots happy or sad. But what we found, and we've done enough studies to show that when a robot emotes with a child and it's an equivalent manner, then the child will engage for longer periods of time. So if the child is frustrated and being able to recognize frustrated, if the robot's going like, yeah, great, 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 you're frustrated, that doesn't work, right? If the child is happy and the robot's like, oh man, you're losing, I don't know what's going on, right? The child is not going to continue that relationship. And so the robot has to be emotional, but has to be emotional in an equivalent manner so that the child would engage. And this has to do with that, you got this small amount of time to keep them engaged. If they switch, you need to switch with them. And so that's part of that. And so that all works together, and we've done a bunch of different studies that show the outcomes. Typically, our studies go from 8 weeks is our norm. And just so you know, getting to 8 weeks as a technologist was like amazing, and it still seems like it's really long. But 8 weeks is just enough to basically, like you'll see, is preclinical, it's pilot. Like you can't even say like it's real work. Like in the clinical literature, it's like, oh wait, it hasn't been a year? Like you're just playing at this. Again, I'm like 8 weeks is a long time to have robot hardware actually work, like reliably, like for an academic, maybe not for companies, but for an academic, like that's like, oh yeah, that took a lot of engineering. In this world, even 8 weeks is like, yeah, it means it's a feasibility study. It's not real. And so we continue to try to push that to get to that 10 weeks and the 12 weeks and then the 16 weeks. So we again, just a little, another study with typically children with CP to show that when the robot is there, it's present. So I want to talk about one last thing as we conclude this. And I teach an ethical AI class. I would be remiss if I did not discuss ethical AI. And one of the motivations is because we interact with kids, vulnerable population. When we interact with them, we are manipulating behavior, and I clearly state that. We are manipulating behavior for their good, but we are actually changing what they're doing so that they have better outcomes. But at the end of the day, that's what we're doing. We're making socially interactive because we want you to engage in therapy for a longer period of time, like all these, and basically that's what we're doing. Humans do it too, so that's not the problem. The problem is that we found that some of our systems may be manipulating incorrectly. And so this actually came from one of our studies. It was a study, children with autism, and we were doing our pilot, which is the actual for engineer, that's the real work. And what we found is in our pilot, our results for girls was different than boys. And we were like, wait, that makes no sense. It's like a robot and therapy. What's going on? Like same emotions, whatever. And so, and again, it was not a statistically significant difference, but there was a difference. Like there was a trend. And so we're like, okay, let's like poke on this a little bit. Maybe it's nothing. And what we discovered after figuring out, you're like, okay, maybe there's confounding factors. Let's hold this constant. Let's remove that, and trying to figure out all these things. What we discovered was that children with autism, higher diagnosis, boys, higher incident rate with boys. When we were taking all of our observation data and all of our pilot data and all of this, it just so happened, engineers were like clinicians and kids, like that was our lens. It happened to be clinicians and boys. Like it didn't even occur to us that it was any different. And it's only because there was such a higher incidence of boys. And our pilot, because it was our pilot, you have to think about this. So you want a more balanced data set. Like you want to do everything when you're thinking about your pilot, right? Because you want to be able to publish and show like age distribution. And so we were really concerned at that stage of making sure we had good representation. But in our observation, it was just like, let's collect data. We need to figure this out. And it didn't even occur to us. And so what our data was representing was the fact that our training set was based on clinicians and boys, not clinicians and kids. And it dealt with the emotions. So the recognition of the emotions was off for girls versus boys is what happened. And so of course, we're like, okay, we got to fix this. Like this is not going to work. We can't have different outcomes for girls and boys. That would really like totally mess up our publications as well as the impact that we possibly could have. And so going a little bit deeper into this emotion. So first of all, I won't say all, most of the emotion recognition systems that are out there, right? Like they're kids, they don't really work, right? Like if you put a 5-year-old child facial video in some of these systems, they don't work all that well. And so a couple of reasons is one is that if you think about a lot of the emotion recognition, the way that things are codified, they have adult codifiers, it's not kids. And guess what? Kids are able to recognize kids better than adults are able to recognize kids. Like, okay, that's obvious. It's like one of these things like, yeah, that's obvious. It's like, because kids look at themselves all the time and adults don't look at kids all the time. So it makes sense. There's also some other biases like you're more able to recognize your gender. Like, why is that? Well, of course, you're looking at yourself in the mirror every day. Like you can recognize when you're happy or sad. And and so it's like these things that seem so obvious, but they're like after the fact. And so we took it upon ourselves to say, okay, how do we fix this? How do we change this? Because remember, we had all this data. We can't just throw away all this good data. Like it's good data, right? So what can we do in order to fix this? And so what we found is that we can build on top of it. So now in all terms of all of our algorithms, when we figure out, now one of the issues, limitations, is that we can't fix it until we've figured out that there's a problem. So that's one of the limitations. But we know, and we've been able to develop these basically, think of it as a filter. So we can take a system that's already been trained and add this filter once we identify that, oh, we didn't have enough girls in our training set, and add it on, and we get the same results when we do these actual trials. Which means that, because again, data is valuable, you don't want to throw, like they say, you don't want to throw out the baby with the bathwater, right? And so how do you keep that data but still build on it? And so we're able to do it, and so we know that it can be done. So next steps, I think about this world, I think, my bias lens is I think healthcare is the application, I think is going to be the killer application, mainly because we all want to be healthy. So it impacts every single person on this earth. I think that's why it's the killer application. And I mean, I don't know about you, but we all get sick, we all get a little bit of cold at least once a year, right? Like, think about this. Health is this one thing that we all agree is important. And so I think that's one of the reasons why this killer application, and we're getting older and there's not enough human resources to address this. But I also realize that there are these things about, we're changing behavior, and we're changing it based on, what I believe and what the clinicians I work with believe. And if I'm working with a different set of clinicians, it might be that my protocols are going to be different because they may have a different viewpoint. And so really being conscious of that as we continue pushing this in terms of healthcare, realizing that we are changing people's lives, I think for the positive, but there could also be a detrimental impact if we're not careful. And so with that, this is just impact outside the lab. We push this in terms of our apps. Everything's free so that others can adopt it. And thank you to all of my students, clinical collaborators, and so on. And that's it. Thank you. I'm going to open up for questions.
All right. Take a few questions so people can come up to the mics. Okay, let me ask you a question first. So
just so you know, I'm an academic. I can literally talk for 2 hours. I have no problem doing that. So ask your question, and I will take the rest of the 10 minutes unless someone else does.
Okay, I guess one question is coming at this from the robotics perspective, and you think about the way that people are interacting with robots is a different kind of test case for you. How would that inform, let's say, the you of 10 years ago about things you would do differently when you're focusing on building the robots in the first place?
So I would, what I talked about today was all of the positive things, but there were a lot of false startups. Because not paying attention to the target demographic, thinking I knew better, like thinking I knew that this is the gadget that this population should use and work. I have as many videos of older adults working with technology. I know older adults they're a different demographic. They interact with technology different. Me assuming that because I work with kids, of course, older adults would love my robots, and learning a year later that that's not the case. So really making sure I understood the target demographic before building.
Right. Excellent. Okay, we've got a question in the back.
Hello. Thank you. I really enjoyed the talk. I was curious about how, if you have any data yet, looking at participants long after the end of the trial period, because a lot of other brain training things for older adults in particular have shown deficits for that, but other video game-like systems have had more sustainable effects. And so I'm curious what you found.
Yeah, so limitation is that there is, and the last slide I showed a little bit of a bump, I just passed by it, that when the robot isn't present, there is a negative, so it doesn't go, if I start off at say baseline 0, I get better with the robot present. When I remove the interaction of the robot, you actually go down to lesser outcomes on all the measures, but it's better than where you started. And one of the things that we do worry, and we don't know yet, and so that's why we're trying to get longer, is at what point will you have this retention? And we don't know. And in fact, most of the studies out there don't know yet. Yeah.
All right, another question in the back.
Thanks for the talk. We all are dealing with technology at a greater scale, and sometimes we get addicted to it. With kids, they might get addicted to this technology. Did you see any side effects of that sort, or what did you see in that aspect?
Yeah, so this addiction, like if I talked about when we removed the technology, they didn't have as good of an outcome. So one of the things, and this is should you have kids interact with tablets, should you have them interact with computers, should you have them interact with robots, it removes their ability to socialize with other humans, so there's a whole slew of research that claims this. But what we find is that we are able to translate that behavior to other people. So if we have a child who wasn't socializing, say, with their peers, what we find is that when we take that child, they've interacted with the robot, it's socially appropriate. When we take that child and put them in a different environment, they actually interact with their peers in the same way they did with the robot. Which basically means that technology has this ability to translate human interaction. I think that's the one thing a lot of the researchers that say we shouldn't have kids connected to technology is that if we design technology so that it enhances social interaction, like all the things that we talk about, like have our robots, like if the child yells, for example, maybe have the robot say that's not polite, right? Like that kind of behavior could translate to better human-human interaction.
All right,
I'm done.
excellent.
Jeremy,
Okay,
I have a question.
oh, one more question.
I had a question about the potential role of mimicry here, where if you think about the robot's movement and potentially changing the movement to match the child, especially with something like cerebral palsy, could it be something that could help engage them further by, like you start by being closer to how the child would behave and then slowly change their behavior over time?
Yeah, so the way we traditionally do the mapping is that we figure out a correlation. So the robot doesn't have the same kinematics or joint configuration, but what we find is that, for example, if we want a child to go faster, like movement time, what we have is the robot will say, oh, this is my speed. I want to do this, right? And the child actually is able to match what they're doing. And the way we do it is that all those kinematic metrics, the robot adapts based on if it's time versus range of motion versus shoulder, but it does this kind of mimicking. And it doesn't have to be, it just has to be a relative thing. It doesn't have to be an exact because the robot doesn't have the same, it doesn't move the same.
Right.
But yes.
Thanks.
All right, excellent. Okay,
Thank
let's
you.
thank the speaker one last time. Thank you.